Well, it's a pleasure to be with you all tonight. I haven't done a webinar in a while. It's always weird doing these webinars because you're just talking to your screen and you assume people are out there listening to you. So hopefully y'all are out there. Hope you all had a good day at work. I had a long day at work, so I was rushing home to get here in time to do this webinar. But I'm excited everything went smoothly, and I'm here to chat with y'all about Revive. Um, I've been very fortunate to work with NuSmile for almost the past year or so in developing Revive and kind of using the prototypes early on to give them feedback on what worked, what didn't work, what we thought we could improve upon. And so I think we're on like with the new release of Revive, I think we're probably on like the fourth generation of different prototypes that they've been working on to get these just right. So it's really exciting to finally have them out and to let everyone else kind of have the fun that we've been having with using these new crowns because they're really awesome. Let me move on here. My screen isn't clicking. Let me see. There we go. So that's me. I'm Matt Lucero. I'm in Denver, Colorado. I have a little Instagram that I post, interesting things on every now and then. If you're inclined, you can follow me, Dr. Matt in Denver, and I'll try to just keep it with interesting clinical photos and things that might be helpful for you. A little history about me, if you don't know me, I grew up in Reno, Nevada, went to the University of Nevada. When I finished there, I was ready to get out of Nevada. I'd been there my whole life, and so I went to the furthest place away from Nevada that you could possibly get, I think. And I went to Fort Lauderdale, Florida for dental school at Nova Southeastern. Very close proximity to the beach, which made dental school extra challenging because I was in that close proximity to the beach. But I had a great 4 years there. Met a lot of good people there, and at the time, my goal was to not see kids at all. I had no interest in seeing kids at that time. So I wanted to do an AGD where I could kind of be like a do-it-all general dentist. And so I moved to San Antonio and went to the VA hospital AEGD residency there. And I learned a ton there. That's where I kind of really that I learned how to be a dentist and learned how to, think critically and think through cases and things like that. And I learned a ton there. I learned, implants and full mouth rehab and all the fun stuff that general dentists get to do. But then I went out into the real world, and those of you who are associates or have been associates, you realize that it's hard to sell those treatment plans, when you're kind of inexperienced and just kind of figuring things out. And then a lot of the owner docs don't want to buy you equipment and things. It's hard to request an implant kit when that's not what they do. So after a while, I kind of got disillusioned with general dentistry, went into public health just to kind of get back to basics and start doing what I went to dental school to do, and that was just do some dentistry and have fun. And it's at that public health clinic where I started seeing children and really, fell in love with doing pediatric dentistry. Um, the kids are more fun. The procedures are quick, and you get a little bit more like immediate gratification, which I really love. There's no lab work. There's no, gross adults that you have to deal with. And so after working in that public health clinic, I went back to Oregon Health and Science University in Portland, Oregon, and had a great couple years there. Elizabeth Palmer was my residency director back then. So if you're out there, say hi, or I'm saying hi, and hope you're doing well. And if you know her, tell her I said hi. JC Stoffer's the new residency director. She's a lovely person as well. So if you know her, tell her I said hi. But had a great couple years there. The weather in the winter is a little gray, a little wet. And so we moved back to Austin where I was living before and started a practice right before the pandemic, had bad timing on that. And so once we kind of finally got out of that pandemic hole, I ended up selling that and then moving up to Denver where I am currently. That's a little bit about me. Quick disclosure tonight. NuSmile has provided financial support for this presentation and materials for the practical training of pediatric dentistry. They sent me these prototype Revive crowns to kind of take images and give you all examples of what these crowns can do. There are some images from other clinicians who have done some treatment with these crowns as well, and I'll credit those when they show up. So our goals tonight, pretty general goals, but we want to find out what Revive crowns are, because I think a lot of folks, when this product was released, were kind of questioning, like, what is this? Like, why do we have this other new material? And, is it similar to zirconia? Is it similar to Bioflex? Which it is not, and we'll go into why it's different. It's not Bioflex at all. And then why were these crowns made? Like, why do we need this? We have all these anterior aesthetic options already. What's the need for another anterior aesthetic option? So we'll go into that as well. We'll talk about the procedure for doing these crowns, the prep involved, kind of step by step, some suggestions I have for making these a little bit easier for yourself. We'll talk about cementation processes. I think most people will be happy with the cement process because in general, it's pretty much you can use whatever you want, which is really nice. These are really easy crowns to work with. And then we'll talk about some kind of tips and tricks to kind of make your ReVIVE cases a little bit easier and help you implement these into your practice as well. So, what are these crowns? Kind of basically, what are these made out of and what are they? So in general, they're kind of a proprietary material. It's a resin ceramic reinforced composite formula. It has 30 years of history in the dental field. So this has been used in general dentistry. And this particular technology has kind of combined all these properties of resin and ceramics, and then they've engineered them to meet kind of the needs of us as pediatric dentists. So there's a resin base and then the ceramic reinforcement. That resin base provides toughness and durability, flexibility, not a ton of flexibility. So this isn't like a BioFlex type of flexibility, but there's some minimal flexibility in this material. Ease of handling, superior aesthetics because it's resin based. It's going to be very pretty. And then the ceramic reinforcement is going to give it kind of the more strength type of quality. So the mechanical strength, abrasion resistance gives a little bit of color stability, and then like that enamel-like translucency, which we'll see in some of these cases we have coming up here. So here's a kind of intaglio surface image and then kind of an image of the facial surface of these crowns. They're really, really aesthetic. They're really beautiful, really highly polished. But they're basically, like we mentioned, like a high performance ceramic reinforced composite. And they have kind of a universally dispersed ceramic filler incorporated into that polymer matrix. So if you can imagine, you have these polymers that are kind of stitched together and kind of interspersed in that matrix, you have those those different ceramic fillers. So these are 3D printed prefabricated crowns, and these are manufactured by NuSmile in Houston. They're all manufactured right there on their premises, and these are registered with the FDA. These are metal-free restorations. They're biocompatible. So you'll see in some of these healed cases that we have coming up how well the tissue responds to these. It's not exactly the same as like a zirconia because zirconia is very, very highly biocompatible, but you get a really nice tissue response with these crowns as well. And you don't have that metal, that you have with a resin or yeah, with a veneered SSC. If you have any rotations and things like that where you start seeing that metal substructure. There's a little bit less tooth reduction, and it's going to be, slightly less than a zirconia. I don't want to, overblow it and say that this is a really, really light prep, kind of like a strip crown. It's not quite that, but it's going to be kind of more towards like a zirconia type of prep, but with a little bit less aggressive circumferential reduction. If any of you all do like a signature crown or a veneered SSC, it's going to be kind of more towards that type of prep where it's not quite as aggressive as it is for a zirconia. And then they have a plaque resistant surface. So it's a really highly polished surface. You're still going to get some plaque retention. For those kiddos, especially that aren't really great brushers, you're going to get some of that pellicle attachment. And you'll see some plaque on recall, but you're going to get a lot less retention than even like a natural tooth. You'll see a little bit less plaque. And then that FDA registration it just ensures that the patient safety and the product effectiveness is there. So the FDA, keeps track of all these. These are class 1 medical devices. And so they're registered with the FDA accordingly. They have enhanced retention, and I'll show you here in a photo coming up with the intaglio surface retention that's built into these. So they have a sandblasted intaglio surface that kind of gives you that micromechanical retention. And then they also have these kind of island patterns that are built into the 3D printed structure of the crown that kind of gives you a more macro retention kind of along the cervical third of the crown or near the margin of the crown. I mentioned earlier about the cement compatibility. The really nice thing about these crowns is that there's no special cement that you have to use. We'll go over it in more detail, kind of suggestions that I have for cement. But really, in general, you can use whatever you want. So if you use like a straight glass ionomer cement, like a Fuji one or a Keytac, powder liquid type stuff, you can use that no problem. If you're more of an RMGI person with like a Fuji Sem 2 or a Reliax luting cement, that works totally fine. If you really want, you can bond these. So if you have a tooth that's kind of broken down, you need a little bit more like structural integrity to it, you can also bond. Might make the cementation a little bit more challenging, but you can bond these as well. Like I mentioned, this proprietary material, even if they told me what it was, I probably still wouldn't know what it is. But it has 30 years of history in dentistry in general. So we know that it's a functional material. We know that it's biocompatible. And this version of it is just kind of geared more towards a pediatric application. One other thing I should mention before we move on from this slide, these are universal crowns. So if you're familiar with zirconia, we have like right side, left side, you have like A1R, A2R, A1L, A2L. These are just universal. So you'll just have A1, A2, A3, B1, B2, B3, C1, C2, C3, and so on. So there is no right or left. These are fully universal. So it's a little bit less that you have to stock at your office. So here's the intaglio surface. Like I mentioned, it's etched and it also has that macro retention with those islands kind of along the cervical third of the crown. But you can see there all that kind of micro retention built in. That just gives you more surface area. And as we all know, the more surface area we have, the better retention we're going to have for these crowns. And then that macro retention just adds to it. So these are highly retentive crowns. They stay on really well. There's no special treatment to the intaglio surface like you might have with the zirconia crown. You don't have any try-in crowns with these. If you get them contaminated with blood or saliva, you just have to clean them off and you can cement them right away. So no special treatment for that intaglio surface either, which is really nice. So most importantly, maybe more important than what ReVIVE is what it is not, because a lot of folks, when they saw this product being released, they were wondering, is this similar to zirconia? Is it similar to BioFlex? And it really is neither one of those things. So it's not zirconia, it's not BioFlex, it's not an anterior BioFlex. This is made from a different composition. So BioFlex is a hybrid resin polymer, so that's what gives it that flexibility and kind of that ability to hug the tooth a little bit. This is a resin ceramic, so totally different handling, totally different feel. It's going to be probably, in my opinion, probably more towards like a zirconia. It's going to feel more similar to a zirconia because it's rigid and solid like a zirconia is. But it's nothing like BioFlex at all, completely different. The prep is not like BioFlex either. So you're going to have a little bit heavier prep. BioFlex, you can get away with a little bit less circumferential reduction because you want that little bit of flexible retention. You want these to be passive, more like a zirconia crown. There's a QR code here on this slide as well. There's a whole FAQ list that NuSmile has put together. So if you want to scan that, that'll give you a little bit more information on the kind of the frequently asked questions about ReVIVE as well. So these crowns also have really great mechanical properties. NuSmile does a lot of in-house testing on these materials before they release them. And so we have a lot of information on the compressive strength and on the fracture resistance of these crowns. The compressive strength is quite a bit higher than the one competitor that's out there that has a similar type of crown on the market, 40 plus or minus 4 newtons. And then the fracture resistance, which is kind of the more important property when we're talking about like the fracture resistance in the mouth and the ability to handle the occlusal forces of our patients. So that's 457 plus or minus 81 newtons, whereas the average bite force of a child's 357 newtons plus or minus 64 newtons. You can see the main competitor there down below is still within that range of the bite force that a child can create. So a little bit higher risk of fracture in the mouth versus ReVIVE, which is kind of far beyond what that bite force is. They also do some mechanical testing with like wear resistance and fracture resistance in the lab. This one is one that they do with the machine. I believe it's called a Leinfeld machine, where they kind of go through cycles, hundreds of thousands of cycles at an 80 Newton load. And what they're doing is replicating 4 years or so of intraoral use. And the result of all those tests showed that there were no fractures. And so that's kind of similar to what we've seen so far for those of us who have been using these crowns the past year or so. We don't have any failures that we're aware of yet. No fractures, no wear through, nothing like that. So I'm assuming that at some point in the future there will be failures. Every material is going to fail at some point. But so far with this material, we haven't seen any real concerns mechanically, at least. So I like to show this research article quite a bit in all the lectures that I do, because it kind of explains the reason why we might want to consider a crown like this versus like a strip crown or a resin strip crown that a lot of us do typically. Resin strip crowns in general, at least the takeaways from this article, were that parental satisfaction with resin strip crowns was pretty high. They're clinically acceptable. These are good resin restorations. These are things that I do in clinic still. I'll use these on older kiddos that I don't need a ton of longevity with. But the take-home message from this article was that these crowns are typically deficient in function with longer follow-up periods. So in this article, they define that as about 20 months. But if we think about it, a lot of the kiddos that we see that have early childhood caries are going to be the younger kiddos, right? So we're seeing like 2, 3, 4-year-olds that have early childhood caries where we're doing these types of restorations. In most instances, we need more than 20 months of longevity out of these crowns. So when we're seeing these younger kiddos, a resin strip crown might not always be your best bet. And this image from that article kind of shows what a lot of us see all the time. And that's, breakdown at the margin, recurrent decay, decalcification, fractures, chipping. So all the things that we'll see at longer and longer follow-ups, this is kind of what that image shows. And so I think for a lot of us, if we are looking for a crown that we want to use on our younger patients, we need to look at something that hopefully has a little bit more longevity than the strip crown, but also has the same level of aesthetics. So these are some case photos of mine actually, and these are healed cases that I've gotten some recalls on. These are ones that I did kind of early on. These are I believe, the first or second iteration of these crowns. But you can see on the left-hand side there, really nice tissue response. There is some plaque accumulation. This kiddo is not the best brusher in the world, but really nice tissue response and really nice aesthetic result. The kiddo on the right also not a great brusher, as you can see. A little bit of inflammation in the gingiva there, but same idea, like really nice aesthetic result. No metal, which a lot of our kiddos who have Medicaid, that's what we're left with for an aesthetic option is a veneered SSC. So we don't have any metal show, really nice translucency. So these cases really turn out nicely, and the parents really like them. The aesthetics are really wonderful. And so far, like I mentioned earlier, we don't have any known failures at this point. I'm sure something will fail at some point. There's no doubt about that. But at this stage, everything's been looking really great on recall. So why Revive? Like, what's the reason why we would choose Revive over some of our other options? Because we do have reasonable options already. So why would we choose Revive over something like zirconia? And for a lot of us who see Medicaid patients, the limits on reimbursement are really like the primary barrier. A lot of states don't cover zirconia at all. Some cover it, like in Colorado, where I'm located. They cover zirconia, but they cover it at a lower reimbursement than even a stainless steel crown. So it really gets hard financially to make that make sense for a crown that costs more, takes longer to do, to get reimbursed less. It makes it really difficult to make that a good option for patients. So this code for this crown is D2932 versus zirconia, which is 2929. So a lot more insurances, PPOs, Medicaid coverages will cover this crown versus a zirconia crown. But like I mentioned earlier, there's a little bit less reduction, so it's a little bit easier to do clinically. The universal design makes it a little bit easier for reduced inventory, so you don't have to have as many crowns stocked all the time. And it's a little bit less expensive. So when you're refilling those kits, the per crown cost is a little bit less. When you're comparing it to like a signature, which is a veneered SSC, kind of what we talked about, you have that zero metal visibility. You don't have, if you have a rotated tooth, you're not going to see that metal substructure. You're not going to have the chipping of that veneer, which is a big issue that we run into. You're going to have a little bit, quite a bit more translucency and aesthetics with signature. You're not going to get any translucency at all, and you're going to get actually wider Medicaid coverage. I know right now for a lot of us, the signature crown is kind of our go-to for Medicaid patients, but there are still some states that don't even cover that. And if you look at the reimbursements, more states even tend to cover the Revive crown versus the signature crown. And these are even a little bit less expensive than signatures as well. Signatures are actually very labor intensive to make, and so the cost for those is higher than the Revive is right now. And we've already talked about strip crowns a little bit. You're going to get better longevity than with the strip crown. The placement is actually a little bit easier with strip crowns, as we all know. We have to control that bleeding and that isolation for the entire length of that procedure. So while we're etching, while we're bonding, while we're curing, we have to keep that blood under control the entire time. So any bit of oozing that you're getting from the gingival margin, we may have to go back, re-isolate, and start that process all over. With the Revive, you really just need to beat the blood to the tooth with your cement, and then you're good to go. So a little bit less blood control or hemorrhage control is necessary with Revive versus a strip crown. So Medicaid coverage, I've talked about that quite a bit already. If you look at the map there, you'll kind of see where the coverage is for most states. And this isn't an exhaustive map of the entire country. There might be some minor differences here and there if you check your handbook. But in general, the majority of the US, Medicaid-wise, is going to cover this code 2932. So I would suggest that you double check yourself in your state and make sure that it's covered where you are. But pretty much, I would say that the vast majority of the country is covered with 2932. Unfortunately, folks in DC are not covered, and those other states that are colored in light blue there aren't covered as well. So here's kind of a comparison when we're talking about the aesthetics of a pre-veneered crown versus Revive. You can see this case on the left is one that I did a while back, and this was a repeat customer. You can see the throat pack there. So it's not often that I get to see a ton of my recalls. A lot of my patients kind of disappear over time, but it's always nice to see a healed case and how things are holding up. And this case actually is holding up pretty well. But in general, the aesthetics aren't quite the same. You can see the Revive on the right, a lot more translucency, a lot more lifelike aesthetics versus those signature crowns, those veneered SSCs, where everything's just, everything's opaque. You can see that little bit of substructure kind of showing on tooth number D. And then, a lot of us are running into those fractures, and what do we do with a fractured veneer? It's not easy to replace. You have to typically cut that crown off and replace it completely. And if it's on a kiddo that you saw with sedation or general anesthesia, that might not be a good cooperative patient for treatment anyway. So being able to cut that crown off, put a new crown on, might not be feasible in the first place. And then do we charge for that? If they don't have coverage for that particular tooth anymore with their insurance, are we going to bill them for that? So there are a lot of challenges with fractured veneers, and with Revive, we don't have that issue. Here's a comparison of zirconia versus Revive, and this is done by Dr. Larry Johnson out in North Carolina. And for those of you who are familiar with these crowns, you might be able to tell, which is which. But in general, the aesthetics are pretty similar. The crowns on the left are NuSmile ZR, and the crowns on the right are Revive, where she prepped these out of Crossbite a little bit. But the aesthetics are very, very similar. I have a hard time, really seeing the difference between a zirconia and a Revive crown aesthetically. So if you're comfortable with doing NuSmile ZR, or even if that's something that you haven't gotten into, Revive is going to be a really nice way to transition into something more aesthetic that's going to be, more approachable clinically and still give you the same results, because these are highly aesthetic crowns. So we'll get into the preparation. NuSmile has the prep guide on their website, and it'll also come on the lid of your kit. So we'll go through this. I made a couple little adjustments on the way that I approach these preps. But in general, like we mentioned a few times already, these are going to be similar to a ZR crown with a little bit less circumferential reduction. So we'll go through this step by step. And this is a quick little kind of way that I approach these crowns that I'll describe to you. But I had an anatomy instructor back in dental school who always told us to work smart, not hard. And I didn't know what that meant back then, because memorizing body parts, I don't know how you do that smart and not hard. But now that I'm doing, dentistry, I start thinking about what he said, and I'm like trying to think of ways to work smart and not hard. And so this approach kind of helps me think things through and gives me a little bit more of a more approachable prep for doing these types of crowns. This is from an article actually out of China, where they 3D imaged the pulps within these primary teeth and kind of mapped them out so you can visibly see kind of where they're at. And then for these preps, it kind of helps out a lot, because a lot of folks tend to think that if you're doing a zirconia prep, or if you're doing a Revive prep, that the reduction is such that you're going to end up into the pulp and you're going to have to do some sort of pulp therapy. But you really shouldn't have to with these crowns. Obviously, if the decay is into the pulp, then yeah, you'll go in and do your pulp therapy. But in general, with the reductions that you should be doing for any of these types of crowns, you really shouldn't have to go into the pulp unless there's some sort of outlier, some sort of anomaly. And, I've run into it where there's just a big giant pulp within a tooth. But in general, the vast majority of our teeth, we shouldn't need to go into the pulp for. So when I'm walking through these preps, when I'm thinking this through, if I'm looking at a radiograph, this is what I'm picturing. So I know that we have to do about 1 millimeter of incisal reduction. That's easy. But then when I'm doing my interproximal slices, I'm picturing kind of where I want to end that finish line of my prep. And what I'm picturing is that there's a lot of convexity to the interproximal surfaces of these teeth. So they're very convex on the mesial and on the distal. And all of that is extra tooth structure that you don't really need to have there for these crowns to seat. And so when I'm prepping them, I'm imagining my burr kind of slicing right through that convexity and falling out into the space down below. And once we do that, we're going to have all of our reduction, and we're going to have a feather edge finish line, which is what we want to have 360 degrees. And if we do that, we can do all of that kind of in one slice. And so ideally, that's what our prep should look like when we're done prepping. And that's what that tooth should look like within the crown itself. It should be well within the confines of that crown. And then when we're done, we should have a crown that sits right at our finish line and should be passive on the tooth. You want a little bit of passivity so that you don't fracture these crowns, similar to a zirconia crown. But that's kind of how I think about it. When I'm looking at my x-rays, I'm looking at where that convexity is, where the tip of my burr can fall out the bottom, and where I can create a really smooth finish line. From the proximal, it's kind of the same. Kind of same idea when we're thinking about this. We're going to do our incisal reduction. We're going to do about a millimeter or so reduction on the facial surface. And then on the palatal, really all we're trying to do is just remove the cingulum and then round all of our line angles, transitioning interproximally. But for bigger cingulums, you're going to do a little bit more reduction. For smaller cingulums, you'll do a little bit less. But in general, we're just kind of trying to flatten out that cingulum so that our crown can seat down passively on the palate as well. And that's how it should look within our prep. Obviously, we'll be rounding all of our sharp edges and line angles and point angles, but that's kind of what our prep should look like within the crown itself. So we'll go step by step kind of for the whole process with Revive here. Step one, I always suggest like trying these crowns end to end with the teeth before you've prepped them. You don't want to get to the end of your prep and then just start randomly trying crowns on, because you might get one that fits passively, but it might be too big for the tooth itself. So if you have an idea where you're starting or where you're trying to head, when you get to the end, if that crown isn't seating, then we know, okay, we need to reduce a little bit more to get this on. If you put a crown on that's too big, you're going to end up with a kind of an unesthetic result. And you may not be able to fit. They may not fit mesiodistally, so you might go to seat them both, but they don't seat together. They might seat individually, but not together. So as long as you kind of have a roadmap of where you're heading, that makes the whole process a little bit easier and a little bit more straightforward. So this kiddo, I believe, was an A3. So we found a length end to end that worked well, and that's what we worked towards. So our first step is going to be incisal reduction. I like to use a donut burr for this. The width of that burr is about a millimeter. So once I kind of get to the width of the burr, then I know my incisal reduction is done. So here's just a little video of me doing that. And I just did this case, I think, on Monday. So this one's a fresh one I made specifically for tonight. But this is just kind of a slow motion version of me doing that incisal reduction. You can do this really in about like 3 or 4 seconds on both teeth if you want. And that's kind of what we should aim for, is about a millimeter or so of reduction on the incisal edge. Next up will be the interproximal slice. What I like to do for this is I'll put like a little bit of a notch about a millimeter in from the mesial or the distal surface. And that's going to be my guide for me to go all the way through. So this is kind of my process in doing this. Make a little bit of a notch just like that. And then I'm just going to do like brush strokes all the way through. So we're going to work our way through that notch, all the way out the bottom of that convexity like I mentioned. And as it flakes off, you'll end up with a totally smooth finish line, and you'll avoid any trauma to that adjacent tooth. And this works really well for like ease if you're prepping up against a 6-year molar. As long as you can see that little sliver of enamel, you know you're not hitting the adjacent tooth. And once you're all the way through that bottom of the convexity, that little sliver breaks off, and then your interproximal prep is done. That works really, really well for me. We'll skip all the other slices here. So we've done our slices on the mesial and distal on both E and F. And then we'll do our facial reduction. So when I do that interproximal slice, that drops the tip of my burr into the sulcus. So I'm already subgingival. And then I'll use the tip of my burr from that area subgingivally to work my way into the sulcus on the facial and on the palatal. What that helps me avoid doing is kind of poking my burr into the sulcus and creating trauma. So if I start off subgingivally, I can just work my way through the sulcus and start doing my facial reduction. So you can see there on the mesial, I'm already subgingival. I've worked my way into the sulcus, and I just follow that sulcus around doing my facial reduction. So you'll get a little bit of bleeding. There's no way of avoiding that. You'll get a little bit, but you're really avoiding the majority of the trauma. And that makes stopping the bleeding later on a little bit easier, because we'll have to get hemostasis before we cement these crowns. So you just want to limit the amount of trauma that you're creating to that gingival margin. Then we'll do our palatal reduction. In the instructions, they suggest using a football burr for this. I don't always use a football. I'll usually just use that burr that you saw on the previous slide, and I'll work my way around the palate, and I'll start kind of leaning that burr into the cingulum and reducing it that way. I know Dr. Johnson, who I mentioned earlier, and Dr. Clark Morris out in North Carolina, they do the bulk of their supragingival reduction with a football burr. So they just kind of take all of the bulk of that tooth down to about the gingival margin, and then they'll switch to a burr similar to the one I used earlier. They'll go subgingival, and then they'll get rid of all that subgingival tooth structure and create a smooth finish line circumferentially. That works really well for them. I haven't been able to replicate it and get as comfortable as they are with that. But you can do your palatal reduction kind of however you want. But in general, what you're looking to do is just kind of reduce that like gingival half of the tooth. I don't do a whole lot of reduction on like the concavity of the lingual surface. I will round those line angles kind of as they wrap around from palatal to mesial and palatal to distal. But I don't really touch a whole lot of the concavity on the lingual surface of that tooth. I focus everything kind of down low in the gingival half. Then we'll go through and we'll just kind of refine the prep. So with these crowns, or with any crown in general, you don't want any sharp angles. So no sharp line angles, no sharp point angles. You want everything rounded, rounded, rounded. Any kind of sharp angle will catch on that intaglio surface and it'll prevent you from seating that crown. And when that happens, you tend to think that you have to do a lot more bulk reduction or something's way off with your prep. And a lot of times it's not a whole lot. A lot of times it's just something that's kind of pointy or sharp that's still hanging on there, and you just need to round it out. So be really mindful of that before you start trying on crowns, but just make sure everything's super, super round. And then we'll do our try-in. Ideally, you want these to sit kind of below the gingival surface or get down into the sulcus. I like to show this photo especially because it shows how translucent these crowns are, which really explains why you need to get the bleeding under control and make sure that if you have any dark spots or SDF staining or affected dentin or anything that's dark, it will show through on these crowns. So you got to be mindful of that. But you can see how much kind of blood is showing through there. So if you have any hemorrhage or any bleeding that you haven't controlled and you go to cement these, you will see that through the crown for sure. So be really careful with doing that before you cement these crowns. In general, like I talked about with these crowns, you want them to fit passively. And so if you feel any resistance, if you're pushing these on and you're hitting kind of any bit of a brick wall or a dead end, you want to make sure you go back and refine your prep. These crowns really should fit fairly passively where you can put them on, take them off without a whole lot of effort. You should kind of feel like a soft finish into the sulcus. When it hits that soft tissue, you should feel it kind of just gently sit into the sulcus. But if you feel any resistance, don't force these. These are I mentioned they're flexible. They're not a ton flexible when you start forcing them onto to an under prep tooth. So I have fractured these. So just be very, very mindful of making sure that these are totally passive before you seat them. Any kind of like little imperfection, like I mentioned earlier, this is a little image that Dr. Morris made. And I think it's a really good, example of the tiniest little bit of a sharp angle that can cause these crowns to not seat. So it can be just a little bit of a ledge or a little bit of a shoulder if you leave a chamfer and go back and remove it. It may be something very, very minute, but you just need to go back and make sure you smooth those things out if it's not seating. This is an image of kind of a hairline fracture that started with a prep that wasn't quite prepped or enough. And so you force this crown on, you'll get a little bit of a propagation of a hairline fracture, and then you'll end up with something like this. So if you force these on, I have fractured one on a tooth that I didn't prep quite enough, and they will fracture a little bit, even a little bit easier than like a zirconia will. But if they're passive, they won't do that. So you just need to be very, very mindful of that. So here's what I do to clean out the intaglio surface. Like I mentioned earlier, there's nothing special. There's no IvaClean. There's no try-on crowns. There's nothing you need to do special when you're trying these crowns on. I just do some water and then blow some air, clean them out that way. And the mechanical retention is all you really need from these crowns. So that sandblasted intaglio surface, those little islands of retention, that is all you need to hold these crowns on. So no special treatment for the intaglio surface if they get contaminated. Then I'll go in and I'll stop my hemorrhage, like I mentioned. So we're working on getting hemostasis before we cement these crowns. What I like to do is just infiltrate the area. So I'll take some local anesthetic. I'm going to blanch the papilla, and you can see there where I'm injecting is a little bit back from the gingival margin. So I don't want any little bit of bleeding from that injection to start creeping towards the teeth as I'm cementing. So I try to keep it far away. I'll inject and kind of blanch that whole papilla. As you see that blanching spread out, that'll slow the bleeding down a little bit. And then I'll go in with some Viscostat Clear and I'll paint that around the sulcus as well. I'll try to prep these at the beginning of my case, and then I'll go back into the posterior, do my posterior treatment. And by the time I get back with the Viscostat and with that local, typically it's going to look a lot like that right-handed picture there where there's not any bleeding and you have a really nice isolated area to cement these crowns. Then we'll fill the crown with cement. You want to use a little bit of excess cement. That image there in the middle might have a little bit more than what you necessarily need for cementing these. But you do want to get a little bit of a collar of cement at the gingival margin. That ensures that you don't have any voids. It also makes sure that if there is any bleeding that happens after you cement them, that you're not going to get that bleeding creeping into the intaglio of your crown. I like to use a dual cured cement. We'll chat about cements here in just a little bit. But I prefer to use a dual cured cement because I like to tack my crowns into place. And because these crowns are translucent, you can tack cure these. So I like to use Biosem. There are some other dual cured cements like Fujisem Evolve that works really well with these. Like I mentioned, you can use whatever you want. Just keep in mind that if you're using like a glass ionomer or an RMGI, you're going to have to hold those crowns in place while they set up. For me, I like to tack them and then I'm good to go. with cleanup and getting those seated completely. Here's a little video of the biosem after I've tack cured them. And this is another one of the reasons why I really like dual cured cements is because once you tack them, cleanup is really, really simple. So I don't try to wipe off the excess cement. I leave that in place because once I tack it, this is kind of what will happen when you go to remove that cement. So you can sneak your Explorer under the surface of that cement, peel it right off, and you get a really quick and easy cleanup. You'll notice that my finger is holding onto the incisal edges as well. When you tack cure these, that cement isn't going to be fully set within the crown itself. It's really just kind of curing that exterior cement that you can clean up. So you don't want to move these crowns once you tack cure them. So I like to hold them in place and then keep all of the pressure of my Explorer or whatever instrument I'm using towards the gingiva so that I'm not pulling up on the crowns and potentially dislodging them. And then this is our final result. So you can see our pre-op there on the left versus our result on the right. Really nice aesthetic result. I try my best, like I mentioned earlier, to avoid trauma to the gingiva. Sometimes it's unavoidable and that'll happen no matter what, but it really gives a really nice finished result. And parents, especially if you're doing a general anesthesia case, are already a little bit antsy going into it. And so if they see their kiddos and everything's nice and clean and there's not a lot of trauma to the soft tissue, it just makes that post-op conversation a little bit more comfortable. It also helps you along the way clinically too with controlling that hemorrhage. So the best you can do with protecting the gingiva, the easier you're going to have during the whole process. And there's our pre-op and our post-op radiograph. You can see the crowns themselves are pretty radiopaque, and you'll be able to see these really well in the radiographs. A little bit better even than like BioFlex if you're familiar with that. But they show up really nicely radiographically as well. So adjusting and cementing ReVIVE, we talked about cementing a little bit, about hemostasis, but with adjusting, there have been some questions about whether you can adjust these crowns or not. When your prep is ideal and these crowns seat completely, typically you don't have to adjust these. You shouldn't have to. But if you see any kind of misalignment or angulation where you want to round a line angle or a point angle, you can do a little bit. I would just suggest doing it very, very minimally. Like if you take a fine diamond or if you take a white stone or an enhanced tip or something like that, you can go in and do a little bit of contouring with these. But I would be very careful because these are very thin crowns. They'd be fairly easy to perforate them if you get a little too heavy-handed with it. We talked about cement options. We've talked about this a few times, but in general, you can use whatever you want, RMGI, GI. Like I mentioned, I really like a dual cured cement. It makes the process a whole lot easier. It allows me to keep the crowns exactly where I want them. So once I get them aligned where I want them, you tack them, you let go, and you're good to go. So my preferred cement is Biosem. That's the one I go with zirconia and with ReVIVE. But Fujisim Evolve works really well. And like I mentioned earlier, you can use a composite resin. It's going to make the process a little bit more difficult, obviously, because you have to keep that isolation for a bit longer. But really for that, the most logical reason for that would be like if you have a really broken down tooth and you're trying to add a little bit more integrity to that tooth when you're doing these crowns, you can use a composite resin, and that'll strengthen things a little bit more, I think. There is a QR code here on this screen, and this will just take you to NuSmile's site for Biosem, which will walk you through the steps for Biosem, because there are a little bit of nuanced steps to the Biosem that makes it work because it's a bioactive material. So there are a couple little waiting periods with that particular cement in order for it to work at its best. So some cementation tips, again, confirm a passive fit. I think that's really, really important with these crowns. Like I mentioned, I have fractured these if I forced them onto an under prep tooth. So make totally sure that you're passive before you start cementing. Clean the intaglio surface well. Water and air work just fine. Like I told you, you don't have to use IvaClean like you do with ZR. You don't have to do any special process or sandblasting or anything like that. Just rinse it and dry it. And then use your favorite cement. Use whichever one you're comfortable with in your clinic. Once seated, especially for like a light curable cement or a dual cure cement, I like to let it sit for about 10 seconds before I tack it. A couple times I've tacked them too quickly, and I think what's happened is it just doesn't have time to incorporate into the dentinal tubules and really kind of do what it's supposed to do. If you tack it too soon, then you're creating a polymerization and it doesn't have time to really adhere to the tooth. And so I've had a couple of debonds, and what I kind of narrowed it down to is that I might have tack cured a little bit too quickly. I like to, really tell people take your time with aligning crowns, especially if you're using a dual cure. If you tack them and they're not in the alignment you want, there's no way to go back and fix that. You've already kind of polymerized that cement. And so getting back to where you can reseat those crowns is kind of impossible at that stage. So be really, really mindful, take your time, One thing I notice is if I use the tips of my fingers and I cover up the incisal edge and I have a lot of cement kind of covering the facial of the crown, I can kind of lose sight of the alignment of those crowns. And so I like to use kind of the tips of my fingers or my fingernails right on the incisal edge. That'll show me if there's any kind of cants or tipping. And that gives me more visualization of the entire crown before I tack cure them. When you tack cure, if you are using tack cured cement, uh, test your light out a little bit before you start using it. It's usually about 2 to 5 seconds. If you're using a Velo, it might cure it a little bit faster. If you have an older, less powerful light, it might take a few more seconds to get it to that kind of rubberized stage. And then clean the cement flash before your final cure. If you cure it too hard, it might make cleanup a whole lot more difficult. And like I said, keep consistent pressure on the incisal edges so you don't dislodge those crowns while you're cleaning up. So here's an example of a case Dr. Clark Morris did of some minor adjustments. This is a really nice case here, but he didn't like the alignment of one of those teeth. I think is number F here. And if you look into this next slide, he went with an enhanced point, rounded that incisal edge, and kind of brought it back into alignment with tooth number E. And for doing this, like I mentioned earlier, I would suggest using like an enhanced point or a fine diamond. You might even be able to use something like a white stone. But be very, very gentle with these. These are very thin crowns. And just be very mindful of avoiding perforations on these. Here's a case that I did early on. This is the one I showed you earlier from that example, but this was the process clinically of what we did to do these crowns. That's our prep there, kind of similar to what we talked about earlier in the step-by-step, and that was our immediate post-op. So again, just taking really, really good care of that soft tissue, controlling the hemorrhage and making that whole process a lot simpler. And that's her post-operatively healed up, like we showed you earlier. But you can see that plaque accumulation on D&G. So that kind of shows you why we were restoring those teeth in the first place. Here's another case of E, F, and G. So this is kind of an asymmetric case here. D didn't have any decay, but you can see aesthetically how well these teeth blend in, even if you're not doing a full symmetric case. So with signature crowns. Even with some zirconia cases, like getting these to match up and look aesthetic when you're not doing everything symmetrically, D through G or C through H, can be a bit of a challenge. But these crowns aesthetically work really, really well in that scenario. Here's a case where we just did the laterals. So this, I believe, was that patient, that healed patient's sister that we saw on the same day. But she just had decay on D and G. We did a pulpotomy on tooth number G, and I covered that with some neoliner to seal it up while we prepped. But you can see on tooth number D, there was some darkness. She had SDF placed, and we got the majority of that out and left a little bit of that stained dent in there. And I thought we would be, safe to cement the crowns at this stage. But if you zoom in, you can see on D that there is that little bit of shadow showing through because of the translucency from the crown. So this was kind of early on when I learned, we really need to be mindful of blocking out any discoloration, remove as much as we possibly can. If we can get it all, great. But if there is still a little bit, you can go back in there with a liner, something like neoliner. If you don't have neoliner, Limelight works really well, Theracal, something like that that's going to kind of opacify that area and block any discoloration from showing through because these crowns are very, very translucent. Here's a D through G case, just kind of your run-of-the-mill D through G. But these are, like you said, these are so aesthetic. And, I really wouldn't be able to tell the difference between these crowns and a zirconia, to be honest. If someone asked me, is that zirconia or Revive, I wouldn't really be able to tell you. So the aesthetics on these are really, really great. This is a case Dr. Evans out of Oklahoma City did. He preps things hemifacially, so he'll do the left side and then the right side, and then he'll cement left side and right side. So he does a little bit differently than I do, but still gets really, really great results. This case is interesting because this is before the lower incisors came out. So O and P are actually zirconias and D through G are Revives. So you can kind of compare the aesthetics on this one case here. And this is that case healed. And you can see the attached gingiva is really, really tight, pink, healthy, really nice tissue response with these crowns. Here's another case that I did, D through G as well. That's our pre-op radiograph, pre-op photo. And then on the top right there, you can see a healed photo. This is a photo one of my colleagues took with an intraoral camera. So not the most vivid photo in the world, but it does kind of give you an idea of the gingival health when these cases heal up. They respond really nicely. Here's a case Dr. Clark Morris did as well. This is a really nice result. Mimics the shape of the teeth it gives a really nice aesthetic result post-operatively versus a signature crown, a veneered SSC. This is light years better than what that aesthetic result would have been. So really nice case that Dr. Morris did there. Here's another D through G that I did, kind of a run-of-the-mill D through G again, but same idea, really, really gentle on the tissue, makes the whole process a little bit easier. But you can see like this case here with that subgingival decay would have been a more difficult strip crown to do, isolating that, keeping the bleeding under control. This crown actually makes things a little bit simpler and a little more straightforward. Another D through G here. This is that patient that I showed you healed earlier. This was her immediately post-op. But you can see what the preps look like, similar to like a signature crown prep, a little bit less aggressive than a zirconia. Here are a few more asymmetric cases. This is an EFG case, no decay on D. Again, really, really nice aesthetically. This patient actually got strip crowns on the lower incisors. So you can kind of compare the aesthetics between a strip crown and the ReVIVE crowns. Similar aesthetics, but those ReVIVEs are going to hold up a lot better. I occasionally will do strips on the lower incisors just because those don't take quite as much of a beating as the upper incisors do, and they tend to hold up okay. But we do have ReVIVE lower incisors as well. This was before those were available. Another asymmetric case, don't have a pre-op. This is just the post-op, but again, really nice aesthetically, blends into the smile naturally, looks really great. Here's a single tooth case that I did. This kiddo had some trauma. We did pulp therapy and then just did a single ReVIVE crown on this. And it turned out really nicely. You can see the gingival height's a little bit higher than the adjacent tooth, but as that heals, that should kind of migrate back down. And in repose, like in a normal kind of presentation where he's not fully retracted, you're not going to see that difference. But from the middle third down to the incisal third, that's going to blend really nicely and look natural as well. This is a case Dr. Morris did too. I like this one a lot because it kind of shows what a lot of our patients have with bruxism and attrition. When we do these crowns, they're kind of an average length of a natural tooth. And so if our kiddos have attrition or they have bruxism, they're going to be a little bit shorter than average. And when you do these crowns, they're going to look a little bit longer clinically. So keep that in mind when you're doing them. If you can seat them a little bit further subgingivally, you can drop them down a little further so the incisal edges line up. But if you're not able to drop them a ton subgingivally, you might end up with a little bit longer incisal edge than the adjacent teeth if you're not restoring all four of them. So keep that in mind. I've done some cases where kids are really heavily worn in the anterior, and I do, D and G, or I do just E and F, and they end up a little bit longer than what they would naturally look like. So as long as you're aware of that going into the case and you prep and kind of plan the case accordingly, that can help mask that a little bit for you. So we've got some final ReVIVE crown tips. I would suggest being proficient in all anterior aesthetic restoration. So not just ReVIVE, not just zirconia, not just strip crowns, because you never know who's going to come in. We have kiddos that come in that have zirconias on D through G, and now they have decay on C and H. We have kiddos that come in with veneered SSCs and they have new decay. And so it's always good to have every tool in your toolbox available to you and to be comfortable using any of those restorations. So I would suggest, just be comfortable with everything, because if you need to match up with something that's already there, it's nice to be comfortable doing that for the kiddos. Base your decisions on longevity required and the clinical conditions. So, if you're not able to isolate a tooth well, or if you need 4 years out of that tooth, strip crown might not be for you. If a kiddo's 5 years old and we're having a cooperative, easy visit, then a strip crown might work just fine. But if we need longevity, you want to think about something like a ReVIVE crown or a zirconia crown or a signature crown, but base your clinical decisions on that longevity that you require. Keep all sizes in stock. Sometimes an A6 walks through the door. You may not see one for 5 years, and then that one outlier walks through the door. And when you have that A6 in your kit, you're happy you have it. Create a game plan for hemostasis. Part of that is how we're going to stop the bleeding, but also part of that is taking care of that gingiva to limit the amount of bleeding that you're going to get. Use radiographs to visualize anatomy, kind of like I showed you with that contour of the tooth. If you know what that tooth is shaped like going into it, it gives you an idea of what your endpoint's going to be, and you can approach the prep that way to get an appropriate fit for your crowns. If your crowns aren't passive, really you want to reduce circumferentially. It's very rarely that you need to lean the prep in a little bit more and add more tapers. Usually that circumferential gingival third of the tooth where you need to focus your reduction to get that crown to drop the rest of the way. Only pulp if the caries or if some weird anomaly dictates it, like I mentioned with big giant pulps. But really for me, like 99% of the time, I'm only pulping if the caries is into the pulp, not because I'm doing a particular type of crown. Remove or block out all your discoloration. Like I mentioned, these are very, very translucent crowns, so any discoloration will show through. Make sure your crown is passive. Forcing will lead to fracture. Use a slight excess of cement, especially if you're tack curing, and that'll avoid internal voids and it'll make the cleanup a bit easier. Seat and adjust your crown alignment before tack curing. Take your time with that. Don't tack cure or feel like you're in a rush, because that's when you end up with cants and rotations and things that you can't correct later. So take your time, get those crowns where you want them, and then tack cure them. Prepare guardians for alternatives if you're unsure, because not every patient is appropriate for every crown. If you have a lot of crowding, a lot of rotations, that can make these types of crowns more difficult. So go into the case, as optimistically as you can, but also give yourself an out. Let the parents know, hey, this might be a difficult case for this type of crown. Are you comfortable with this alternative? Most parents are pretty easygoing and accepting of that sort of thing, but don't ever corner yourself or make it difficult on yourself. These are the kits that are available. There's a starter kit and there's a professional kit. I always suggest getting the professional kit. Like I mentioned in the tips, you never know if some off the wall size is going to come in, if an A0 or an A5 or a B6. You never know. Like you don't see a ton of them, but the one time that you need them, you're going to be happy that you have them. So the professional kit, it's always going to cost a little more up front, but gives you a little bit of peace of mind knowing that you have what you need no matter what. And if you want to get some hands-on, you can only learn so much through a webinar. Hands-on is really the best way to get more comfortable with these types of crowns. So we have a lot of options available for hands-on courses. There's the Pearls in Austin, which is a women's course. I've heard it's a lot of fun. I'm not invited, unfortunately, but I've heard it's a really fun time for the folks down in Austin. There's one in Orlando coming up. Dr. Morris is going to be leading that one. I'll be assisting him down in Orlando. In Chicago, I'll be actually leading that one, so that'll be a good time. Summer in Chicago is always beautiful, so maybe come hang out in Chicago. And then there's one in Los Angeles on August 1st. So if you want to get your hands on with some of these materials, ReVIVE will be there, Zirconia. Every one of NuSmile's products will be available for you to work with hands on. So come visit us at one of these upcoming hands-on workshops. And that's it, y'all. Thank you very much. I think we've made it just before 7 o'clock my time, so we'll have some time for questions, I think. But thank you all very much for your attention tonight. I appreciate it.
Awesome. Yeah, we do have a couple of questions. I do want to add as well. We'll have, if anybody's attending AAPD this year, we'll have some workstations set up at the booth for everybody to get some hands-on with ReVIVE and all products as well. So we do have a couple of questions.
Okay.
I'll get through these, but let's see here. All right, first question. Can they be autoclaved or cleaned another way after trying?
Yes, thank you. Thank you. That's really important. Yeah, so autoclaving is completely fine with these crowns. It really just autoclaving is kind of the way that I do all of my crowns. I know Dr. Morris and Dr. Johnson in North Carolina, they cold sterile theirs. That works as well. But NuSmile, in their in-house testing, they've run these through the autoclave, I think more than 10 times each. There haven't been any mechanical property changes. There haven't been any color changes or shade changes at all. So these are totally fine to run through the autoclave.
Next question is, how do you mask SDF treated teeth?
Good question. Yeah, so there's a couple ways. SDF only penetrates so far. It's under a millimeter or so in most studies that I've read. So a lot of times you can prep this out with just the normal prep of the crown. So the vast majority of them I just kind of prep out. But if you're already starting with kind of a deeper cavitation that has staining in it, there's a limit on how deep you can go, right, without ending up in the pulp. So I'll go as much as I possibly can with my handpiece and kind of remove it all as mechanically as I can. But if there's any leftover, I'll go in with a liner. So my favorite one to use is Neoliner. It's really thin and kind of lays down thinly onto the tooth. It's very opaque, so it'll block out any discoloration. But if you don't have Neoliner, any of those kind of light curable liners work well for blocking out discoloration.